Today's talk is about alcoholic liver disease. It's a topic that I thought was very interesting because it's a disease entity that we admit to the MICU and other ICUs on a pretty weekly basis, if not daily basis. And it's a pretty challenging disease to manage, and it just has such a high mortality. So I thought it'd be interesting to take a look at the literature in terms of the mechanisms for pathology, and then also the treatments that we have available now to treat this disease, and then treatments being made available going forward in the future. So the objectives are going to be to review some background and epidemiology. We're going to be looking at the spectrum of the disease, the pathogenesis and risk factors, some of the prognostic scoring systems, treatment options, alcoholic liver failure in the ICU with its complications and management, ECAD, which is a type of liver dialysis system that's been around for the last 20 years, and then liver transplantation. So the background is that liver disease is a pretty important cause of morbidity and mortality in the United States. The economic burden is just ridiculously significant, and we spend a lot of health care dollars treating this. Liver deaths account for about 48% of cirrhosis-related diseases and up to 20% of the transplantations that we do in this country. And despite the profound economic impact and health impact alcohol liver disease has had, there's been little progression made on the management of these patients. So this was a study put together by the NIH that came out in the 1990s that looked at the economic impact of alcohol abuse in the U.S. And at that time, the amount of money being spent per year was about $185 billion. That amount has significantly increased since 2006. It's about $226 billion that we're spending. A significant amount of that money at the time, $129 billion, was based on lost work productivity. 26 of that was healthcare dollars, and then another 29 billion was on issues related to social welfare and crime, traffic incidents, suicide, and fire destruction. So why is alcohol abuse such a big issue for us in the United States? Well, here in this country, and like so many Western countries, it's very much integrated and incorporated in our cultural lives and our social activities. So everything from celebrations to weddings to parties, the booze will flow. But the question is always, how much is too much? So if you take a social event like happy hour, and you want to look at what's a standard drink in the United States, so about 0.6 fluid ounces, which equates to about 14 grams of alcohol per drink. So if you look at a 12-ounce beer, the alcohol intake is about 5%. A 4-ounce wine is about 12%. And if you look at hard liquor, 1.5 ounces, whether it's brandy, whiskey, rum, whatever's your poison, the content is going to be about 40%. So if you say, well, what's my risk for developing alcoholic liver disease? The time to development is equal to the amount of alcohol that you're consuming. So for men, it's 60 to 80 grams per day for a 10-year period, which comes out to be about 4 to 6 drinks per day. And then for women, interestingly enough, it's significantly less. We only need about 20 to 40 grams per day for 10 years. And that comes out to be about 1.4 to 2.8 drinks per day. Yeah.
What about the weekend warning?
We're going to talk about patterns and habits of drinking.
Personal risk.
And
she is really upset. I said, what about the size of the ratio over here?
We're going to talk about that as well.
I don't know. I mean, not for no reason.
Exactly. No one care more.
What's your personal risk, Raj? No comment. Okay. So alcoholic liver disease has a pretty broad spectrum. You have patients that can have a normal liver, and then they can present as far along the pathway as hepatocellular carcinoma. So 90 to 95% of chronic drinkers that have alcohol intake of up to 60 grams for men, 20 to 40 grams for women per day will end up developing fatty liver disease or steatosis. 20 to 40% of those people go on to develop fibrosis. 80 to 20 will develop cirrhosis, and then 3 to 10 will develop hepatocellular carcinoma. And what's also interesting is that there are additional risk factors and comorbidities that actually act in synergy to accelerate the progression of this disease. So things like viral hepatitis, HIV, being a woman, obesity, your drinking patterns, smoking, and dietary factors. So we'll actually take a closer look at a few of these in the coming slides. So the risk factors: alcohol dose and duration, the type of alcohol that you're consuming, drinking habits, sex, ethnicity, obesity, iron overload, infection with viral hepatitis, and particularly hepatitis C, genetic factors, hemochromatosis, and HIV. So for women in particular, we have a lower level of gastric alcohol dehydrogenase. We have a higher proportion of body fat and a higher presence of estrogen, and so that leads to a progression of the disease. For those of us that are overweight or maybe considered obese, that in itself does cause an acceleration of fibrosis and actually leading on to the development of cirrhosis. And there are a lot of experimental studies that have looked at the synergy effects of obesity, and they have identified things like type 1 macrophage activity that's causing problems for these people. If we talk about habits, somebody that drinks on a daily basis or narrowly heavy daily drinking, and it starts at an early age, they're at high risk. There are certain genetic factors that have been identified, people that may have mutations or variations in their antioxidant enzymes or cytokines, that could be playing a role. And then there was 1 or 2 studies that looked at this gene called PNPLA3, and it's supposed to be responsible for increasing cirrhosis in white alcoholic subjects. So if we look at the pathogenesis of alcoholic fatty liver disease, it's a very busy slide, and so we'll just summarize what we're alluding to. And so basically what's happening is that alcohol intake is leading to the upregulation of a number of, is there like a pointer on this?
There should be the middle.
Oh, okay. Duh. So alcohol intake leads to an upregulation of a number of transcription factors like SREBP, and also leads to the downregulation of a number of transcription factors like PPAR alpha. And what basically happens is that the hepatocyte is very much impaired in its ability to oxidize fatty acids that's coming in. Also, alcohol also is related to the way the hepatocyte is able to utilize and mobilize fatty acids. So you have an increased uptake of fatty acids coming in from the small intestine. And so basically what's happening is that you just have a buildup of fatty acids in this hepatocyte. If you talk about the pathogenesis of alcohol hepatitis itself, what's really going on is that you have an activation of both the innate and the adaptive immune systems. And so what's basically happened is that alcohol consumption leads to the upregulation of a number of the mediators. And those mediators actually go on to stimulate not only just the hepatocyte, but the Kuffner cells and the stellate cells to produce pro-inflammatory cytokines and chemokines. That in turn leads to an infiltration of neutrophils and macrophages inside the liver itself. And then with the adaptive immunity, you have an increased release of reactive oxygen species that leads to the breakdown of protein that are presented as antigen to B and T cells. And they actually go on to infiltrate the liver themselves, and this causes a big inflammatory cascade, and we have liver inflammation. And then if we talk about how do we actually see fibrosis, it's pretty much the same mechanism whereby the stellate cell is highly stimulated and activated by a number of pathways. And so what you see is that the hepatocyte ends up developing apoptosis and necrosis. That in turn releases oxygen, reactive species, and necrotic debris. We have LPS and acetaldehyde that ends up being released and stimulates the stellate cells. And that also in turn activates the Kuffner cells and causes a release of cytokines and chemokines. And all these mediators stimulate the stellate cell that's actually releasing collagen into the extracellular matrix, and that causes a lot of liver fibrosis. And then additionally, what alcohol does is that it knocks out the natural killer cell activation pathway. And so your natural killer cells are actually responsible for inhibiting the stellate cells from leading to fibrosis. So when you drink a lot, that entire pathway is completely knocked out, and that's nature's compensation mechanism. So if we talk about the prognostic scoring systems that we use for alcohol hepatitis, the 3 major ones are the Madry's discriminant function, that's circa 1989. You have the MELD score, which is the model for end-stage liver disease, that's as of 2001, and then we have the Glasgow alcohol hepatitis scale, and we'll talk a little bit more about each of those in detail. So the Madry score came from Dr. Willis Madry, who went on to be very much a pioneer in the use of steroids and alcohol hepatitis, and we'll talk about that a little later. But basically why it's so important to use these prognostic scoring systems is because they help us to identify those patients that are at risk at death, and then also those patients that would be eligible for second-line treatment. And so the Madry's discriminant function is used to stratify a patient's severity, and then you have the calculation there. Usually we take the patient's per thrombin time minus their control, and we multiply that by 4.6 plus the total bilirubin. And so patients that have a function score greater than 32, their 1-month mortality is as high as 30 to 50%. Those that have a score less than 32 have a 1-month mortality that's about 10%. If we use the MELD score, it's really good as a measure for determining short-term mortality risk in patients based on diverse etiology and severity. And it's a pretty good comprehensive indicator of the physiological reserve of patients with decompensated cirrhosis. And what's interesting is that a change of 2 points in a patient's MELD score in the first week of being hospitalized has showed an increased mortality. And so I put the equation down there for us, but most of us just go to our app, like here at Mayo Clinic, and plug it in. And so you can see, of course, that when you look at a 3-month survival curve, patients that have an increasing MELD score have a decrease in survival. The third one is the Glasgow alcohol hepatitis score. It's not something we really use that much in the U.S. It's considered to have an overall higher accuracy for most patients, but it's considered to be less sensitive for predicting 1-month and 3-month mortality compared to the Madry's or the MELD. And so the factors that they use are the age, the white count, urea, prothrombin time, and bilirubin. And if you have a score greater than 9, that's associated with poor prognosis. The new kid on the block is something called the allele model. It's actually supposed to be really good at predicting survival within a 6-month time period. And so if you have a score greater than 0.45, your chances of survival are considered to be about 25% or a little less. And so they use age, bilirubin, creatinine, albumin at time 0, and then the patient's prothrombin time. So what do we tend to use? Physical exam, labs, imaging, biopsy, which is not really done so much here in the US, but it seems to be pretty popular in Europe. And so our physical exam, alcohol has no bias, attacks all major organ systems. So neurologically, we deal with encephalopathy, neuropathy. GI, we deal with everything from varices to gastritis. Reproductive people have amenorrhea or testicular atrophy. The skin, they have jaundice, petechiae, purpura. The bone marrow is often suppressed, so they have a pancytopenia and coagulation disorders. Metabolically, you have electrolyte issues. And in cardiovascular, you have fluid retention, peripheral edema, and ascites. And so the labs, you see that both the AST and the ALT are usually increased, usually between 100 and 300. The AST is often elevated more than the ALT in a 2-to-1 ratio 80% of the time, and that's because alcohol does suppress ALT production. You have an increase in GGT, a macrocytic anemia, thrombocytosis, leukocytosis, and then an increasing PT and bilirubin, which correlate with disease severity. You also have high CDT, which stands for carbohydrate deficient transferrin, high IgA, uric acid, serum lactate, low albumin, and high triglycerides. And so imaging itself we use to kind of just diagnose that liver disease is present, and really doesn't help us to understand what's actually causing the liver disease, but you do often see marked fatty infiltration for alcoholics. And the major aim is usually to try and identify if there's any other cause, like an obstructive process or malignancy that's taking place. And so these are just some images of some cirrhotic patients. The top portion of the slide is a gentleman that had some cirrhotic changes, and the left portion is a young lady that had an ultrasound that you see some coarse architecture. And then the right is a lady that also was biopsied, and you can see that she just basically has a lot of Mallory bodies and then just a lot of fatty infiltration in her slide. So the American College of Gastroenterology has a lot of good guidelines for liver biopsy, and basically what they talk about is that patients that have severe alcohol hepatitis and it's just not quite sure what's causing the liver disease, these are the people that we should be biopsying. But they feel that it really should be based upon local expertise, and that center's comfortability with biopsying people that are not only coagulopathic but very severely ill, and that's a class 1C recommendation. So the treatment options that we have to offer are abstinence, which sometimes is very hard because alcohol is an addiction for some people. Proper nutrition, steroids, and pentaxyphylline. So abstinence, it's the most important therapeutic intervention for patients with alcoholic liver disease. It's been shown to improve the outcome and histological features of hepatic injury. It reduces portal pressure and leads to decreased progression of cirrhosis. And it just improves survival overall in these patients. So the guidelines, of course, the ACG, bless you, promotes this. And also treatment with naltrexone and for patients to get the counseling that they need to stay abstinent. Nutritional therapy is very important, especially in the ICU. These patients often come in with significant protein calorie malnutrition. They're deficient in a number of vitamins and minerals, especially thiamine. Thiamine is very important for neuropsychiatric manifestations, and so they develop things like Wernicke-Korsakoff syndrome, cognitive impairment, which is like an alcoholic dementia, and then cerebellar degeneration. So coming to steroids, it's the most extensively studied intervention in alcohol hepatitis to date. The recommendations are based on 13 clinical trials that go back as far as the 1970s. The landmark paper that they had for the use of steroids actually came from a number of authors, one in particular, Dr. Willis Madry, who went on famous for developing the discriminant factor function. And this was a randomized multi-center trial that they did with 4 university hospitals, including Johns Hopkins and the Medical College of Virginia. And what they were basically able to show is if you give somebody steroids versus placebo, will there be an improvement in mortality? And what you can see here by the graph is those patients that actually received methylprednisone did much better. Their 28 mortality was actually 6% versus, was 6% compared to some people that were placebo, and that was 35%. And so this just led to a robust investigation in the hepatology literature for investigating the use of steroids. And you still have some hepatologists that there's a line divided. Some people believe in steroids and some don't. And so those are the 13 clinical trials that the ACG uses for their guidelines. There was also a systematic meta-analysis of those 13 trials. And what they were looking at was basically that those patients overall may have not had a significant beneficial effect when it comes to mortality for steroids, but there was a particular subgroup that did. So those patients that had a discriminant function score of 32 and also had hepatic encephalopathy did seem to benefit. And then they also took a further look at those patients that had that subset of 32. And basically they showed a significant increase in short-term survival. And so people who got steroids, their survival was 84% versus people that didn't, that was 65%. So the typical dosing is using prednisolone at 40 milligrams for 4 weeks, and then you taper that over 2 to 4 weeks. There are some people that think that steroids in the long term probably causes a worsening inflammatory cascade and causes more harm than benefit. And so basically what's happening is that those people that maybe fall in that subgroup that have a function score greater than 54 may be at higher risk. So then you ask, well, what's the patient that we use this for? So ideally somebody that has a score of greater than 32, that has spontaneous encephalopathy, and doesn't have any contraindications like sepsis, GI bleed, or hepatorenal syndrome. The other player for what we can offer to our patients is pentaxyphylline. It's an oral phosphodiesterase inhibitor. It inhibits the production of TNF-alpha among other cytokines. And this was a study produced in gastroenterology in 2000. And basically they were looking at inpatient mortality for these patients. And what they found was that the probability of survival for people who got pentaxyphylline was actually much higher than people that, and they counted that to be over 40% lower than the placebo group. So there was a hepatology meeting that they had in November of last year in Boston, and there was a study that came out of the United Kingdom, caused a lot of buzz and controversy at their meeting, as per Dr. Munka. And this is called the STOPAH Trial. It's something that's coming on stream right now. And we're still waiting for some of their full data analysis to be released. But what they looked at was multi-centers in the UK, England, Wales, Scotland. It was a double-blinded factorial trial, which patients were randomized to one of 4 groups. Group A was those who got placebo. Group B, placebo and steroids. Group C, pentoxifylline, placebo, and Group D got pentoxifylline prednisone. And the aim of the trial was to randomize 1,200 patients, which is a pretty big cohort, with severe alcohol hepatitis to provide sufficient power to determine whether either of the two interventions really were effective. And their primary endpoint that they looked at was mortality at 28 days. And then their secondary endpoint was mortality at 90 days and 1 year. Other secondary endpoints that they looked at was the rate of sepsis, GI bleed, hospital readmission, and new or recurrent renal failure. This is the inclusion criteria that they used. Patients had to be 18 years or older, clinical alcohol hepatitis by an elevated serum bilirubin, history of excess alcohol, less than 4 weeks since admission to the hospital. Their factor score, of course, was greater than 32, and informed consent. They had a list of exclusion criteria that I just put up here for your review. And so the results of the study was basically that pentoxifylline actually ended up having an odds ratio for 28 mortality at 1.0%. At 1.0, prednisolone had an odds ratio of 0.72, and so they basically felt that true at a 28-day mortality, prednisolone was much better. But when you looked out long term, at 90 days and at a year, there was no change in mortality. And they actually also felt that pentoxifylline had no impact on disease progression and perhaps should no longer be used for treatment for patients with severe alcohol hepatitis. So keep in mind, this is just their preliminary data. They still have some more data coming out. Another factor that people are looking at is TNF inhibitors. The two most common that are being looked at clinical trials in Europe is infliximab and etanercept. Unfortunately, these drugs in particular have been having some very poor clinical outcomes in Europe. Infliximab in particular, there was one study that had one arm where they took prednisone 40 milligrams or 5 milligrams of infliximab, and then they gave the other arm just prednisone alone. And there was really no difference in mortality. And the other trial that they did, I think, was in France, where they had infliximab at 10 milligrams of prednisone, and they actually had to stop the trial early because people were dying. And they related the deaths to a lot of severe and aggressive infections that people were getting. So a lot of people, in terms of experts in hepatology, just really feel that these are drugs that really need more studying, and it's just something that we really shouldn't be using right now. So this is what our class of patients look like in the ICU. We tend to see the dramatic and extreme complications of alcoholic liver disease and what we tend to deal with. And we are usually dealing with the complications of end-stage liver. So variceal bleeding, encephalopathy, ascites, sepsis, spontaneous bacterial peritonitis, and hepatorenal syndrome. And so the West Haven criteria uses 4 grades to measure hepatic encephalopathy. Grade 1 is usually a trivial lack of awareness, euphoria and anxiety, shortened attention span. Grade 2 is usually somebody that is lethargic, has minimal disorientation for time of place. They may have subtle personality changes or inappropriate behavior. Grade 3 is somebody that's usually semi-stuporous and less responsive to verbal stimuli and confused. And then grade 4 is pretty much somebody's completely unresponsive or comatose. And somewhere between grade 3 and 4, we find ourselves perhaps intubating these patients. So, of course, we know that plasma ammonia levels tend to be elevated, but they correlate poorly with hepatic encephaly grade for a lot of people. So the management is primarily focused on dealing with the precipitating factors and supportive care. So GI bleed, infections, electrolyte abnormalities, electrolyte non-compliance, ruling out sepsis, and then supportive management with fluid maintenance, aspiration precautions, and then airway protection with intubation if needed. And so the drugs that have been proven for benefit for hepatic encephalopathy include lactulose, rifaximin, zinc, and portosystemic shunt occlusion. The rest have been considered possibly harmful or have limited benefit. So rifaximin, ammonia-producing, fights ammonia-producing enterobacteria. It's an oral antibiotic. We give it twice a day. It's usually an adjunct to lactulose or first line. A lot of other antibiotics have been studied, like neomycin and metronidazole, but they usually are not recommended because they cause a number of side effects like ototoxicity and nephrotoxicity. Zinc deficiency is actually pretty common in a lot of cirrhotic patients, predominantly from urinary losses. Zinc deficiency causes a decrease of the urea cycle enzymes involved in the detoxification of ammonia. And so there has been some literature out there that shows that zinc supplementation to improve psychometric test scores and reduce ammonia levels. Protein restriction. There was a lot of thought initially that cirrhotics and alcoholics, they really should not be getting a lot of protein. That's really been challenged recently because this approach really doesn't consider the detrimental effects of limiting protein. In patients with cirrhosis, they usually have increased protein requirements to achieve a balanced nitrogen metabolism. And so if you restrict their intake with protein, what you'll find is that they start to have muscle breakdown, and that in itself leads to an increase in ammonia. So basically, you want to make sure that they can maintain a positive nitrogen balance to avoid muscle breakdown by making sure they get proper nutrition. And then sepsis, in conversation with Dr. Munka, he says that the two things that he stresses the most to help perhaps limit mortality in the ICU is that one is control of sepsis, and two, making sure that we try to preserve renal function. Those have been the only two things that seem to really improve mortality in our patients. And so we know the cirrhotic patients are at high increased risk for susceptibility for infections, and there are a number of deficiencies that are considered to be responsible, but mortality is increased fourfold. And so 30% of these patients die within 1 month, and then another 30% die within 1 year. And so when we talk about hemodynamic support, there's been a lot of questions about what should the target be for end-stage liver disease patients. It's pretty much unknown, but a lot of people still do abide by some type of protocol-guided management. So we use the Rivers early goal-directed therapy, and so we're trying to meet our parameters as you see below. Another big complication is hepatorenal syndrome. It is significantly responsible for a lot of morbidity and mortality for our patients. There are two types, type 1 and type 2. And treatments usually consist of either using the hepatorenal cocktail or terlipressin with albumin. So this is a study that was actually published in Hepatology in 1999 that discussed the benefits of using midodrine, octreotide, and albumin versus dopamine. And basically, group A was the dopamine group, group B was the midodrine and octreotide group. And what they were basically able to show is that people that got midodrine and octreotide did much better. They actually had an increase in their renal plasma flow. They had an increase in urine sodium excretion, and also an increase in their glomerular filtration rate. One of the most dramatic and often devastating complications we deal with is variceal hemorrhage. The AASLD actually has really good guidelines on management. So these patients need really good intravascular support with blood transfusions, and we try to maintain their hemoglobin at about 8. They really should be getting antibiotic prophylaxis, whether that's with Cipro or whether that's with ceftriaxone. And they should be getting therapy with some type of somatostatin or some type of analog, usually for about 3 to 5 days. EGD should be performed within 12 hours to make the diagnosis and treat any variceal bleed, whether it's going to be with EVL or sclerotherapy. And TIPS is usually only indicated in patients in whom hemorrhage from variceal, esophageal varices cannot be controlled, or in whom bleeding reoccurs despite pharmacological endoscopic therapy. And then balloon tamponade is a temporizing measure, but at maximum, it should only be for 24 hours until patients have a more definitive therapy plan in place. So what about ECAT? So ECAT is something that has been around for about 20 years. It's very popular in Europe and Asia. There's about 45 countries in the world right now that's using this technology. There are only 5 centers in the US that do it. University of Minnesota, Sharp Memorial in San Diego, and actually Emory University in Atlanta are one of the huge centers that are big proponents of this therapy and feel that it works for patients. There are a lot of criticisms and skeptics about this that feel that it doesn't work, but I thought we'd talk about it and pull down the literature a little bit. So ECAT stands for extracorporeal albumin dialysis. The two best known systems are Mars and Prometheus. MARS stands for Molecular Adsorbance Recirculation System. It was developed by investigators at the University of Rostock in Germany in 1993. It didn't get approved by the FDA until 1999, 2000. We use it in the US usually for acute liver failure, so things like drug overdose and poisonings. But as of 2013, it was approved for hepatic encephalopathy due to decompensation of chronic liver disease. Right now, it's not indicated in the US as a bridge to transplant. So the system can remove a number of toxins: albumin, bile, bilirubin, copper, and iron, phenols. So I just showed a picture of what the machine actually looks like, and then this is a picture of what the setup is. And their catheter they use is actually similar to the typical dialysis catheter that we use here. So the design is basically that blood is cleansed in an extracorporeal circuit. That's a combination of kidney and liver dialysis. It's understood that the established methods of kidney dialysis do not work for liver failure because the kidney dialysis only removes water-soluble toxins. The liver is responsible for albumin-bound toxins, or those insoluble substances. So for this reason, MARS uses human albumin to cleanse the blood because it can attract toxins bound to the albumin in the blood, and then in that aqueous solution that kidney dialysis cannot remove. And so basically, it's a system that replaces the detoxification function of the liver. And it's just a further graph of what it looks like. So a lot of hospitals have been really slow to adapt this system. One, it's supposed to be very expensive. I'm not sure what the cost is here in the U.S., but in Europe, they said the initial session is usually about 14,000 euros, and then over a 3 to 5 day session, we're looking at about 40,000 euros. And I think the euro is doing better than the dollar, so you can only imagine what that must be for U.S. money. Training usually consists of a number of sessions and quarterly refresher courses. Setting up the circuit takes about 2 hours. Each session itself is about a 6 to 8 hour treatment. You can use it for 3 or more consecutive days, but it usually requires for 2 dedicated nurses. And this is a list of a number of studies that have looked at MARS therapy. And we're going to talk about 2 of them that's been pretty significant in being proponents for it. So this was a study done by Misner et al. They published this in the Liver Transplant Journal in 2000, and they randomized 13 patients with hepatorenal syndrome, 8 in the MARS group, 5 in the control group, and they looked at 30-day survival as a primary endpoint. The mortality in the control group was 100%, but those that got MARS, their mortality was only 75%. Still pretty high for both, though. But there was some interesting findings. There was some effectiveness found that MARS can actually increase your arterial pressure, your urinary volume, and then they also saw a decrease in the creatinine and the bilirubin. And so I added the inclusion criteria and exclusion criteria for you all to look at, and then also the baseline characteristics of what these patients look like. And so as I alluded to before, people that got MARS, they saw an improvement in their bilirubin and serum creatinine levels. Their blood pressures in terms of their MAPs went up, and then also urinary volume. Yeah.
Is there any data as far as the center, first of all, the centers that use these, are they using them kind of when these people present with like the liver failure and the hepatorenal, or is it kind of like a salvage thing?
So it's interesting because there was a group out of Hong Kong that talked about this particular issue, about when is the optimal time to start a patient on MARS. Is it when they have that very first initial decompensation, or is it something much later in? And basically they end up saying they weren't sure. They weren't sure. But they found, at least anecdotally in their center, the patients that they started earlier, the better that they did. So the MARS group also seemed to do better in terms of cumulative survival. So So another trial that was done by Heman et al. Was actually published in the Hepatology Journal in 2002. And their primary endpoint was looking at a decrease of serum bilirubin. Their secondary endpoint was in-hospital survival. And so what they did was they randomized 24 patients with severe cholecystitis, those patients that had a bilirubin greater than 20, And if they were not improving after 3 to 5 days of standard medical therapy, they would decide to whether or not they would continue standard medical treatment or start them on Mars. What I really liked about this study is that they laid out the etiology of cirrhosis for a lot of their patients, and you can see they had a lot of alcoholics in both their control and treatment group. They also talked about what was the precipitating event for the decompensation, the last drink, the comorbidities that patients may have had, their bilirubin, and then also time to response and time to death. And so any patient that you see has a little cross by their name or patients that died. And so basically what they were able to find is that patients that were actually treated with Mars therapy did much better in terms of reaching their goal of having their bilirubin reduced to being less than 15 over a 2 to 3 day time period. And the actual triangles are represented at people that met this goal. The downward going triangles are people that died through the study. And so you see a lot more downward going triangles in people that were in the control group that received only standard medical therapy. This graph is not as good as I wanted it to be, but this talks about the reduction of hepatic encephalopathy in people that received Mars. And so people that got it, they seem that the range of their hepatic encephalopathy, they tend to stay at lower grades throughout a 4-week time period. People that received only standard medical therapy significantly increased and were in grades 3 and higher. And so basically they also felt that in terms of probability of survival, people that got ECAD just did better overall versus people that were in the placebo group didn't. So the determining factors for decompensation were people that had infection, drug intoxication, hemorrhage, and alcohol abuse. The results showed a statistical difference in 30-day survival for people in the Mars group. There are 6 deaths in the standard medical treatment group against only 1 in the Mars group. And then the effectiveness also shown improvements in hepatic encephalopathy, arterial blood pressure, a decrease in the bilirubin, creatinine, and biliary acids. So what about liver transplantation in alcoholics? I mean, a lot of people turn this into a moral debate as to whether or not this is something people should be getting. But there was a study in France that looked about, should we rethink the whole 6-month sobriety rule? Because in 6 months, the mortality rate is so high, people are dying. So about 80% in the centers in the US require you to be sober for 6 months. 20% of the centers only require you to be sober for 3 months. So this was a very controversial study that got a lot of people just excited, but also very upset. And so we'll take a closer look at it. So the authors, they were about 7 centers in France, felt that the strict application of the 6-month sobriety rule was very disadvantageous to our alcohol hepatitis patients, and that 70–80% of those people die within that time period. And so the aims of the study were to determine whether if liver transplantation improves that 6-month survival rate in those patients that are unresponsive to medical management, and to evaluate the rate of alcohol relapse after transplantation, and then evaluate the burden of early transplantation. And so the patients that they identified as being non-responsive to medical therapy were people that, per the Lille model, had a score of 0.45% or more after 7 days of medical therapy, and they had a continuous increase in their MELD score. And that therapy consisted of severe care for severe liver dysfunction and people who were treated with prednisone for 40 milligrams per day for at least 7 days. And then non-responsive medical therapy they found was associated to the 6-month survival of approximately 25 to 30%. So their selection process was any patients that were non-responsive to medical therapy, people that had severe alcohol hepatitis as their first liver decompensating event, patients that had a close support of family members, had any absence of severe psychiatric disorders, and there was an agreement between the patient and their families and those physicians that they were going to adhere to lifelong total abstinence. So we're just taking people on their word. And so these were the baseline characteristics of what their 25 patients looked like in their treatment group, 26 patients in their treatment group, and they had another 26 patients in their control group. And so their median age was about 47. They had gotten steroids, people who had elevated bilirubins and prothrombin time. And so the median MELD score was about 34. The decision to list patients for transplantation was very quickly made after they weren't responding to medical therapy, so a median of 13 days. And then transplantation was performed as soon after listing, and that was a median of 9 days. And what they found was that patients who were actually transplanted had a survival rate of about 77% at the 6-month follow-up. Patients that did not receive a transplant had a survival rate of 23%. And those are pretty significant odds. I think the one thing that Dr. Munka pointed out that I thought was interesting was that when you look at their follow-up 12 months, their survival rate in these transplanted patients were only 75%. In the US, that's actually considered not to be acceptable. Our transplantation rate should be 90% or higher. So in cases of patients who were alive at 6 months, their liver tests and creatinine levels returned to normal ranges within the first month after transplantation. There was no significant difference between the 1-month and 6-month values of their creatinine, INR, and liver function tests. After transplantation, they were followed for a short interval, a median of 11 visits during the 6-month period. And within that 6-month period, there was no alcoholic relapse that was observed. So that was really exciting because people were like, oh my God, they're not drinking anymore, they have a new liver, they're doing well. Well,
self-reported alcohol relapse?
Well, so visiting, self-reported, but also they had like nurses going out and following up with these patients. That's exciting for the first 6 months. Let's talk about what happens after. So 3 of the 26 patients actually later resumed drinking alcohol. One at 720, one at 740, one at 11 and 40 days after transplantation. And despite counseling by an addiction specialist, 2 of the patients remained daily consumers, and then one just said he drank occasionally 30 grams per week. None of them had graft dysfunction. So the limitations of the study is that it really didn't allow for that rigorous assessment for long-term outcomes. We were really looking at just what happens in that initial 6 months. There's concern that the matched controls may have not been comparable to patients in terms of support from family members and their intentions to remain alcohol-free. And then just reproducibility of the selection process would need to be reattempted. So in conclusion, excessive alcohol consumption, as I said, has cost the United States over $200 billion. Healthcare expenses are usually about 11% of that total. Women and patients with viral hepatitis that are higher risk. Steroids still remains an acceptable therapy choice, showing mortality improvement in 30 days. Alcohol liver failure in the ICU still remains a challenging disease to manage. But the intensive care has a pivotal role because we're providing support for failing organs and allowing time for hepatic regeneration for pre-optimization prior to liver transplant. And ECAD and early liver transplantation, they are very promising and they offer long-term solutions, but for patients with chronic disease, they need further studies. So moral of my story is to just basically treat your body right in the beginning, and in the end, it will return you favor. This is one of my favorite singers. This is Amy Winehouse. She was a 5-time Grammy Award winner. She died at a very young age from alcohol poisoning. And these are the references, and just many thanks to Dr. Munka for his time and help.
Jennifer, the 75%